in D, this listed about a page or slightly less is about 4 pages in the standard of care. Whereas the client selection is correct, it's only 1 page, but the significant disease arising from pregnancy would include all the antepartum conditions, all the interpartum conditions, and all the postpartum conditions that are in the standard of care, which is a much more exhaustive list than is included here. But that's not required in statute. So why are we going to have that?
Doesn't the statute require all the conditions for not only what Carrie stated, but also newborn conditions that require? I thought that's the statute required that.
Not the new language.
Oh.
From the pregnancy. And we do have some things in here that have to do with it.
Carrie, can you talk into the mic?
I can bring some more chairs up here.
Fingers off it up here.
The way that I would interpret this, and please correct me if I'm wrong, Carrie, but if I was an expert reviewer for the medical board and I was reviewing a case where a client, a mother or a baby, was not referred for conditions that are part of the standard of care but are not on this list, I might likely find her negligent. And
I'm sorry, say that again.
I might find her negligent for not creating a referral. And so my point is the, 4 or so pages in here that relate to conditions arising from pregnancy, either during the pregnancy, during the birth process, or postpartum for mother or baby, is more exhaustive than this. Well, and I'm wondering if that's not where we're going to end up with, or whether we have to end up there. Is a shorter list acceptable?
I think we may be talking about 2 different things. So there are things that may be occurring that the statute doesn't demand that we have regulations for, that could still be interpreted by an expert to be below the standard of care for a midwife if they don't make a referral. But the statute demands that we create regulations for these 2 categories, and it's so a licensed midwife shall only assist a woman in normal pregnancy and childbirth, which is defined as meeting all of the following. Right. And it's not talking about the postpartum period as I read it.
Well, in B, though, it says significant disease arising from the pregnancy. And what if the woman has a postpartum hemorrhage? That's a significant disease arising from the pregnancy, and I don't see it on the list.
Well, it is, but there's things where this is talking about normal pregnancy and childbirth. So, childbirth encompasses this period that, there's an immediate period that right. would be encompassed in that. And I hope that I've included some things that address that.
So are you saying then that we can have a shorter list than what was here? That's my question. That's what I'm hearing.
Let me get some more chairs.
So the only thing that we're addressing here are conditions that require physician consultation during pregnancy. That's all we're working on. But that doesn't mean that we don't still have reasons that we can't select a client for care, or that we have to transfer or transport. That's a separate issue that we're not working on today.
Okay. So if I'm understanding correctly, then, because I want to be sure I'm addressing this properly, we can, according to the law, have a shorter list than what is in the standard of care. Am I hearing that correctly?
That is a possibility.
Okay.
And
I'm willing to have that.
Okay. Here's the other reality, is that once we work through these regulations, we are going to have to revisit the midwifery practice guidelines, because there may be things that happen during this regulatory process that then the guidelines will have to be updated.
Okay. That makes sense. I think.
Not to me.
Well,
Okay, let me see if I have it.
regulations trump guidelines.
Right. Let me see if I have it correct now. Okay. So there's a selection and retention. That's one list. That if there's anything on that particular list, we have to refer the client out before we can care for her. Just it correlates with the list in the standard of care, roughly. Am I correct?
That is the headline for both A and B. Now, that may not be the best descriptor of the proposed reg. That's something that's also up for discussion.
I'm wondering if it roughly correlates with the criteria for client selection, which is item 4 of the standard of care LM guidelines, which is a list of if any of these things are present, you need to refer somebody. Is that the current understanding? Not that either list is exhaustive,
Right.
But that's the
Right.
comparison, correct?
Right.
And then part B, the comparison would be the rest of the list in the standard of care, but possibly a shorter list than is what is in the standard of care. Because the rest of the standard of care are things like antepartum referral, what needs to happen during pregnancy and what needs to happen during the birth process in terms of a referral.
Generally, yes, but I don't have the guidelines right here to do side by
Okay.
side, but that is what I started with.
Okay, and as you're reading the dictate of the law, are we only dealing with maternal conditions? Or are we dealing with conditions of the newly born infant also?
Terry, today we're only working on conditions during pregnancy that require referral to a physician. That's all we're working on today.
So we're not working on anything postpartum and nothing with the infant postpartum? Okay.
Right. I mean, I think Ms. Webb was really clear when saying that, during an investigation there, or, any examination of a midwife's practice, we're still going to be looking at these official practice guidelines and community standards. It's not the only thing isn't going to be what's in statute and what's in regulation. The broader standards will be in place.
Right. And in B, I want to make sure I'm understanding Carrie's question correctly, because I have referenced fetal growth restriction suspected, fetal abnormality suspected, fetal demise. So these are things, but they're what
during the
happening
pregnancy.
during the pregnancy.
So I guess just for clarification for everybody that's here, because I think a lot of people assumed, including myself, that we were looking for a list to replace what's in the standard of care in total. And if that's not what we're looking at, then we need to backtrack and decide, okay, so which parts of the standard of care correlate with what we're working on today? And if we're not looking at anything that happens after the delivery of the mother or with respect to the newly born infant, then it'll make the discussion shorter.
Yeah, of course. But use the mic. Everyone wants to hear what Miss Dobbs have to say.
So my understanding is that All we're doing with this regulatory language, this proposed language here, is in A, we are trying to pretty much define the conditions that are considered pre-existing maternal disease or condition likely to affect pregnancy. That's all that's doing, giving you things that would fall under that definition. And similarly with B, it's significant diseases arising from the pregnancy. It's just a laundry list of what could fall under that. That's all we're doing here with these regs.
I apologize because I know you kind of answered this question, but I've now read this about 50 times in the last half hour, and I still cannot see how under this we could continue to take care of a woman who continued having one of these conditions, even if the doctor said it was okay. I mean, it says there's an absence of both of the following. So if over 35 is on that list, I send a 36-year-old woman to the doctor, and the doctor can say, you're in the prime of your health, go home and have a home birth, and it doesn't matter because the law says she has one of the things on this list. She didn't cease to be over 35 when she saw that doctor.
That
Can
is
you help me with
because,
this?
yes, I can. Yes, I can. This will be an easy one.
Okay.
So we're defining those things, but in the statute, under B2, that's where it talks about the referral for an examination by a physician and surgeon trained in obstetrics and gynecology. And then it says, a licensed midwife may assist the woman in pregnancy and childbirth only if an examination by a physician and surgeon trained in obstetrics and gynecology is obtained, and the physician and surgeon who examined the woman determines that the risk factors presented by her disease or condition are not likely to significantly affect the course of the pregnancy and childbirth.
Okay,
So
so
women
that
can still have-
supersedes this statement, which seems inflexible.
This follows that. This follows that.
So it's just that it's not printed here, so, I mean, I
Right.
remembered it, but I thought it was related to another part of the law.
Sure.
So it relates directly to this.
Yes, it does. Right. So if they have one of these conditions, you have to get a referral. If the physician does the examination and says, you know, it's stable, they're doing okay, this probably isn't going to have a negative impact, go ahead and continue care with the midwife, then that's what you do.
And one additional comment on that, and we worked so hard on getting this language just the way that this was a bear, because we were trying to make sure that it wasn't the physician signing off on a home birth, because we're hearing there's a lot of physicians who just would not sign off on a home birth. What we're doing is having the physician using their diagnostic tools and skills to be able to say, is this basically going to be a normal pregnancy or not? And that's why we have it, the verbiage that we do. I wanted to introduce you all to Dr. Kelly McHugh. She's a local OBGYN, is new to our, she's co-chair of our legislative committee, but she's actually been working with us for a number of years, and she's going to be working, helping to supplement Dr. Gregg's work. We actually have another doctor, Dr. Yen Trong, who may be here later, who's a maternal fetal medicine fellow at UC Davis. So you have a lot of really good, interested people that will be able to help guide ACOG. So who's Dr. McHugh?
Hi, being new to the process and to this group and taking a look at this as someone kind of coming in from the outside, what I see is I went through this big exhaustive list real quick and looked at the language that you guys worked so hard to come up with your list of conditions that would require some sort of physician consultation. And what I'm seeing is that shorter list has more broad categories on it. And this particular list kind of gives examples that would fall under the broader categories. Is that, so almost every single one of these that are on here, I can go back and pick a letter category that it falls under in the list that you guys worked so hard to come up with in your meetings before. So from my point of view, that can go either way. If it is the case that the list is really short, then what's on the list is likely to be more general and vague, which can be good for you and bad for you, right? It could be bad for you because it could be good for you because you could say, okay, great, my list is real short. I don't think it's this person has any of these conditions that fall under this short list. Whereas a prosecute, something doesn't go well and then there's a problem and somebody comes back to you and says, oh no, that falls under this list. You should have known, blah, 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 blah. So I think that can work either for you or against you, depending upon what the situation is and how it's looked at. So this longer list has a couple things in it I've seen so far that I would have a hard time categorizing under that broader list. They're kind of odd ones, collagen vascular disease, but they can be pretty important with regard to pregnancy. I don't know that we're all that far off in terms of kind of where we stand depending on which list we use. I think there are advantages and disadvantages to being more specific.
Well, and with regulations, we like to be more specific where we can. So
the way I see that is that this that you handed out just is telling what does it mean to have cardiovascular disease. What are some examples of a disease that a woman might have that would potentially play a role in how her birth goes, and on and on and on, right, for each disease.
Ms. Dobbs, that's okay, specific, yeah, that's where I would like to go in that direction, because then it's more clear for the licensees as well as the clients and anyone reviewing the case.
You certainly wouldn't want to be, if in your position, what I would not want personally is to be in a position where I was thinking A and you were thinking B, and then you came back and went after me. Because in my mind, A meant A, and in your mind, A meant A, B, and C.
That's a very good analogy. Okay, so
is there any liability to the physician who says, yeah, this won't lead to have you ever really found anybody who said, oh, you have a history of postpartum hemorrhage, so you're likely to have a normal birth, when how do we know those might have been hospital births, they might have been mismanaged, there might have been lack of nutrition that could be corrected by the midwife. There's all sorts of things. History is a really awful part of this, because somebody could have a history of alcoholism and been clean and sober for 10 years. There are people who come to us because they don't want to see a doctor. And if they didn't see us, they wouldn't see anybody. So what's safe and what's not safe? Who are we trying to protect people from?
Right.
When we're trying to protect the consumer, do we add in protect them from the rising cesarean section rate? I know it's leveled off now, but still. My cesarean section rate over 30 years has stayed at roughly 5 to 6%. Nobody else in this country can say that, unless they're probably a home birth midwife. What about things like age over 35? I'm going to have to object to that seriously, because that was written in the days when people who were 35 had not had good health care, did not have good diets. Maybe they had 6 kids already. There wasn't any birth control. There wasn't any screening for genetic abnormalities. Somehow, I see a little subtext in here. If you have to go to the doctor, he's not going to let you say you're okay and at low risk to have a normal birth unless you get genetic screening. I have a huge population of people that I take care of who, for ethical reasons, will not do genetic screening. But no doctor is going to let her off the hook for a normal birth until she's had that. This whole document, being more specific, is not always protecting the consumer. It may be protecting the care provider, but it's not protecting the consumer. And if this is the Department of Consumer Affairs, where are the consumers out there? I could have never had any home births under this legislation. I know most of the midwives in this room would have had conditions that would have kept them from ever being a home birth client and probably from ever having a home birth or being a midwife.
When they're ready, we will definitely do that. So Ms. Webb was prepared to go through a bunch of edits already, so hopefully we'll get to that. Just one thing on the specific versus not specific issue. The existing guidelines based on the standards do have history of adverse obstetrical outcome. So while Ms. Webb did specify a lot of history things in this new one that we may have concerns about, history of adverse obstetrical outcome already encompassed all of those. So, you know, it gets into that issue of what exactly does that mean. And if we really wanted to stick with the existing standards, we'd have that term.
Is anyone?
I just want to alert us to something as we consider all of these, which is theoretically we are talking about being evidence-based in what we're doing, right? Okay. There was a 2014 article in the Journal of OBGYN that stated that by analysis, level A evidence in obstetrical care is about 12%. Level B, 22%. Level C, 29%. And recommended best practice with no evidence, 37%. So we're talking about 66% of the recommendations are lousy evidence. In 2011, in OBGYN, another article similar said that the level A was only 9%. Level B evidence was only 12%. Level C was 17%, and recommended best practice with no evidence, 40%. So we're talking about 57 to 66% of all of these recommendations that we are trying to limit not only the midwives, but the women. We're trying to limit the women from themselves when it is lousy evidence. In other words, we're approaching half of all of these recommendations based on expert opinion, not high quality evidence. Yet these recommended best practices are being used to limit choices for the childbearing women or to force them into going against their wishes by shifting what determines their care from treating disease to treating risk. And that is a problem. We have got to be careful that when we are limiting conditions here, when we are limiting women's ability to make their choices and to get care, that we're not doing it based on risk only. We've got to do it based on conditions, on true issues, on true healthcare problems. We've also got to acknowledge that all types of knowledge are potentially valuable and potentially detrimental. So what do we do with that? It's always a balancing act. All knowledge is contextual and thus subjective and biased. All knowledge, due to the viewpoint of the one offering the evidence or the opinion. Also, expert opinion is anecdotal evidence. The only difference is the value that the beholder places on the person who's expressing the opinion. It's typically what launches research. So the experts formulate a question, decide what tests or treatments will be compared, and then define what outcome measures will be used to determine efficiency. But what are they comparing? Are they comparing things that really matter to the women who are going to be taken care of? Midwifery is about individualizing care. That's our hallmark. It's how we get the best possible results that we can. And if you look at the years now, the 7 years that we have of the Licensed Midwife Annual Report, we have wonderful outcomes. We have rock bottom prematurity rates. We have rock bottom low birth weight baby rates. We have way lower cesarean surgery rates than any low-risk population in our medical care. We have to balance all of that and begin to value midwifery judgment. We are about individualizing care, about prioritizing judgment rather than rules, about combining usable evidence combined with context and professional expertise and the autonomy and the wisdom of the women themselves. Midwives see women as experts in themselves, and midwives as experts in keeping their clients healthy and as healthy and normal as possible. These experts must be accorded equal value as those whose expert opinions are based in a different context and bias. Knowledge and expert opinion are subjective, with advantages and limitations on both sides. Please, let's keep this in mind. We are trying to work toward a collaborative arrangement with the medical people. We are a separate profession, and we have overlaps. In order to work best with that collaboration, it must not be a top-down ordering of how things are done. It must be collaborated upon. And I hope that that means that every time something is in question, every time something is being debated, that midwives are always present for all of these deliberations, for everything that is written, as well as the doctors with whom we must collaborate and be collaborative.
Hello, everyone. I guess this is a good point for me to speak because I'm not speaking from the standpoint of a midwife or a doctor. I'm speaking on the behalf of CFAM, which is California Families for Access to Midwives. And so I'm talking here as a consumer. And quite frankly,
What's your name?
Tanya Smith Johnson, I'm sorry. And I'm here, I flew up here from LA to be here to speak on the behalf of thousands of families throughout the state of California who have serious issues with the language in this, the new regulations, the proposed language in the regulations. There are a few points I want to make if you bear with me. The first is that CFAM helped with the AB 1308 and was in the room for some of the wording and language. And we feel that the way that the language is here is that it's narrowing access for women and families based on the way that it reads now. We feel that it does not represent evidence-based and best practices in regards to the midwifery model of care. And it's narrowing the original intent of the law, which was to give more access to midwives to families and let women have the autonomy to choose who they want to see, regardless. And where practitioners are there to give them informed consent, and women have the choice to use that consent or refuse it, meaning that I shouldn't have to. I'm 38, and I guess I'll share this now. I'm newly pregnant with my 5th child. I'm telling you right now, I don't want to go to a physician to ask him to give consent for me to continue to see a midwife for my potential home birth. I don't want to do that. I will not do that. So, and with my last child, who I had at a home birth, I was over 35, meaning I would have had to go to a physician to get a referral consent just because I'm 35 and older. No other risk factors. That's ridiculous to me and many other women. Even though the language came out late last night, so we didn't have much time to go over all of it. There are a few things that we take issue with, one being the age 35. We're concerned and want to be at the table when these things come out. We would like to have a seat at the table as consumers. We would like to be informed in advance when working meetings are happening so we can be there, so we can have our voices heard. Granted that we believe CAM is the best place to look at for us midwifery guidelines, but consumers are who should be contacted, informed about in regards to care that's based on them and their needs. And remembering that the ultimate decision for care should always lie with women. We shouldn't fall back to the paternalistic system of asking a physician whether it's okay for us to birth the way we choose. We need to remember to make sure that we're using the best and most accurate and evidence-based information in regards to how well midwives can take care of consumers. A lot of the things that are on the list, midwives already do risk assessments for. They're very good at that. And they should still be able to do that without having to refer their clients to physicians. Ultimately, it's her choice. It's my choice. It's the women's choices in regards to their bodies, their babies, and where they want to birth. We would love to be at the table with the next time this happens. We weren't. As a consumer base,
this is the table.
I see that I'm talking further along. Can we know in advance when language is going to be discussed so we can be at the table? Can we see the language in advance so we can have time to kind of mold that over? My contact information is tanya.smithjohnson@gmail.com. I will be here. I will sit at the table, and I'm willing to always speak for the voices of the families across the state of California. Thank you.
Now, I want to really streamline our focus to discuss the regulations that we are required by statute to do. A lot of the comments are directed to the language that is in the statute itself that the medical board does not have control over. It went through the legislative process, and we have to do these regulations, and there are some conditions that will require a referral to a physician and a physician sign off. And we have to do it. So I propose at this point we go through what the suggestions that CAM has already started with, and get feedback on that and anything else on the list. But we do have to do these regulations. So anything from you two before we start?
Well, I just think it's time to discuss each thing on the list.
Okay.
I think that's what's relevant at this point because we do have to do this.
Okay.
And, all the theoretical stuff we're never going to agree on. But this we have to do. So let's just talk about the specific things on the list.
Okay. So, if we look at this, yes. So I had a suggestion to strike the history of cervical cerclage and move that to be that if there is basically evidence, and you'll see it down here, of, keep going,
13.
of cervical incompetence in the current pregnancy, that would prompt a referral. Yeah, go up again, please. So A13, I would strike it there because the discussion was that a history of cervical cerclage does not mean that in the current pregnancy it's going to be a problem. And again, this is going to be up for discussion.
And where did you want to put it?
Under B, which is that it's a significant disease arising from the pregnancy. So it'd be in that current pregnancy. If there is cervical incompetence, it prompts a referral.
So it'd be like number 30 or something like that? Like its own new number?
We can't read that from here.
They inserted
Yeah,
it at 25 and changed it to cervical incompetence.
Right here. Cervical incompetence.
This paperwork,
And we can, and here's here's some hard copies. We'll get some more made. That might make it easier.
Can I speak to that?
Of course.
Cervical cerclage, history of cervical cerclage. I see that being a difficult one. That's a hard one to start off with. The reason I think it's a hard one to start off with is because there's two sides to that argument, and both of them could be potentially very strong. So it could be the case that a woman had a history of a cerclage, which was not needed, right? And so then you're looking at that, well, just because she had a cerclage doesn't mean that she had cervical incompetence. If you wait until there's evidence of significant cervical incompetence in the current pregnancy, the ship has sailed and we've lost the game. Because trying to put in a cerclage when that cervix is already effaced so far is not very effective at helping that woman maintain her pregnancy and get a healthy baby. So we have this that's a really, really divisive one for us to start off with. However, if you put it in terms of she's had a history of it, maybe it would be better to put it in terms of if she's had a history of cervical incompetence rather than saying she had a cerclage. And keep it under A. Mm-hmm.
Can I comment on that? So our concern was that not necessarily that it wouldn't be a good idea for the woman to see a physician and potentially have a cerclage in the subsequent pregnancy. Our concern was that that physician is then, in order for the woman to return to midwifery care, the physician would have to say in some form that the woman is expecting a normal pregnancy. And it would probably be challenging for an OB to say that a woman who has had a history of a cerclage is going to anticipate a normal pregnancy, even if she's not showing any signs right then, or you're not placing one right then for whatever reason. Another reminder that even outside of all of these conditions and diseases required in regulation, midwives will refer to physicians for a great variety of things, and that would definitely be one of them.
I have a question. I have a legal question. If it were the case that a woman came in, let's use this example that we have right now with a history of a cerclage, and she was referred to a physician, and the physician said, gee, I don't know, you kind of dilated to like 2 centimeters at 17 weeks. It doesn't sound like your cervix can really hold this baby in. I don't think it's a good idea for you to go have a home birth and maybe not do something about that cervical incompetence when we get to that point in the pregnancy. Let's say the woman said, you know what, I think, you're a jerk and I don't like anything that you have to say and you're lame and I want to go, or whatever they say, I want to go and have this home birth and that's really the most important thing to me. Where does that leave each party legally?
Well, first of all, we can't take care of women who are less than 37 weeks. We cannot do a home birth or have a hospital birth for them.
But I'm
so
talking
we're not
about
going to be attending their births.
But I'm talking about the caring for them during the pregnancy. right? Because they may come in really early pregnant at like 8 weeks when no matter who they saw, nothing would happen just yet, right? Because you're like 8 weeks pregnant.
I have taken care of a person with multiple
Right. So are you, are you an attorney?
No, I'm
Okay. I wanted to know the answer legally.
Oh.
Where does this stand? That my question was of a legal basis. Before we get into the rest of it, I want to know where that puts both parties legally.
So if the woman has a condition that per the statute requires a physician consult and the determination by the physician that it won't have a significant impact on the course of the pregnancy and delivery,
Let's say the physician said, yes, I think this will have an impact. This is not a good plan.
then the midwife needs to either work in conjunction with the physician, and if that's not acceptable with the client physician, the midwife cannot continue care.
Okay.
And this has to be addressed in their disclosures to the client, so that this talk about client abandonment, the clients are going to know that there are conditions that will require a transfer of care, and the client may decide they don't want to do that, but the midwife, under certain conditions, will not be able to continue care.
So in order to sort of adjust the thinking on putting it in the second case, a midwife doesn't want to have somebody having a precipitous birth at 22 weeks when the woman could have used a cerclage. If she comes in with a history of a cerclage and possible cervical incompetence, we watch that cervix early on. We send her for an ultrasound to see if there's any funneling. We convince her, because we have her best interest at heart as well as our own, and we convince her that if there's anything that ultrasound shows or any signs at all, then she will benefit from a cerclage, and you go with her and you have a conversation and you consult together and you make sure she gets the best care possible. I mean, I had a client who had a fast first birth, a second birth. She only had a live baby because she was planning a home birth. When she had a little spotting at 25 weeks and no contractions, her physician, she called, said, I'll fit you in tomorrow. I came over right away. I found her 4 centimeters dilated. I made her lay down in the back of my car, not go in the pickup truck. I made the gurney come instead of the wheelchair to take her upstairs, and she had a baby 3 hours later with no contractions. The baby lived. She had cerclages for her next 3 babies, which she had at home, and they all weighed 8 to 9 pounds. So we work with women from where they're coming from, and we try to provide the best interface possible, but we don't want to be stuck with a situation like you're describing either. And so putting it in the history, I mean, sort of predisposes you to making that that referral where, anybody, if I was a physician and somebody came in with a history of a cervical cerclage, I could not guarantee them, well, nobody can guarantee anything, but I would not say you're, a good candidate for a home birth. Yeah, you may have a home birth, but you put the cerclage in and you take it out at the right time too. And then you can do whatever you want.
Of course.
And you may have a seat as well, so
well, it's not one. My name is Amory Adams. I'm an OBGYN who's practiced hospital-based medicine for over 25 years and am now doing home birth. I actually think that this is a straightforward and a pretty easy statute to start with. I agree that it should be under history. But I think the wording is history of cerclage or cervical incompetence requiring in the current pregnancy, a repeat cerclage, and it should specify before 37 weeks. Because what I'm understanding is, the woman can have concurrent care with her midwife. And when she reaches 37 weeks, when that physician takes out that cerclage, she's 37 weeks, she can deliver at home.
Right.
Is that not correct? I mean, would you disagree?
I think that last part would be correct. The discussion.
But she would be allowed to have care with the midwife concurrently with the physician. If the physician decides to put a cerclage, if he does not feel she needs a cerclage, then she doesn't fit that category of history of cervical incompetence requiring a cerclage in the current pregnancy. I'm not a lawyer, but my father said I should be.
The problem is the two different categories that we're dealing with. So, but I see what you're getting at, and so I want to think about that some more.
She's listing 37.
History of cervical incompetence. Incompetence requires, or maybe it should be in category.
Right.
History of cervical incompetence requiring a cerclage in the current pregnancy prior to 37 weeks. And the woman, what I mean is not requiring a cerclage is what the woman has achieved 37 weeks of pregnancy.
Right.
Once she achieves 37 weeks of pregnancy, she no longer needs to achieve it.
I mean, there's two separate sort of issues here. There's the issue of care during the pregnancy, right? And then there's the issue of, you know, where you deliver and how far you are when you get to that point. And, right, because that's really, it's easy if we say, okay, she had a cerclage, but she got to 37 weeks. Well, that's easy. No, I get it. I fully get that.
I completely agree with you. Yes, the history, you don't want to wait until these 24 weeks and before 30 years. You can't have a clause and stuff on Kendra. She gets the clause, she could be active, she could see the midwife, she could see and have concurrent care with the midwife, which will probably improve her outcomes. And then, because the goal is to get her to 37 weeks with this condition. There's no problem with the woman.
Yeah, cervical incompetence would be her problem.
It's not anything to the risk of the baby or the mother once she hits 37 weeks.
Right. It just risks it all before then. That's the thing. It risks it. It just risks it. It's a big risk before then.
Correct.
Yeah.
So it should be there, but it should be removed.
Can I just make a comment here, because I think we're at odds with each other, but we're not really. I think that this is a more unique situation than some of the things on this list, and I think that licensed midwives are perfectly competent in early pregnancy to determine whether or not there's current cervical incompetence, and observe that really closely and make the referral at the appropriate time. So that the mother isn't referred to the physician at 8 weeks, but there's a collaboration with the physician when it's appropriate to do a cerclage and somewhat before that, so that you can actually get her in, but so that the midwife can initiate care early and then make the referral when it's necessary. So if you put it under history, that's going to generate a referral when the woman enters care with the licensed midwife. If we put it under conditions arising in the pregnancy as history of cervical incompetence requiring cerclage with current cervical incompetence noted, then the referral can be made in an appropriate time frame without wasting anybody's time. And I think what Anne-Marie is saying is that you make the referral, the cerclage is placed, you have concurrent care with the midwife and the physician until the woman reaches 37 weeks, the cerclage is removed, and then she can deliver safely at home.
I think that's fine. My point of contention would be that I think it's absolutely important in this particular example that the counseling about what cervical incompetence, what options that a woman has, needs to happen when they still have the options. And so that discussion and referral to the physician, I think, does in this particular instance need to happen early on, while the woman still has choices. It would be very unfortunate if it were a situation that somebody had a history of cervical incompetence, had lost a previous pregnancy, and did not get true informed consent about that, about what options were and what the risks of each of those were early enough on in order to make a decision to do it or not do it. I completely agree that this is anything I recommend. As the patient, you can say, or, that sounds like a good idea to me. You can say either way. My job is not to get you to do what I think I would do. It's to present you with your options and for the patient to get to choose. But I think that you really, in this particular case with cerclage, you need to have that discussion needs to happen early on, and in order for them to make a true informed decision.
But that's what we do too.
That's what I was just
So I have Ms. Dobbs come up. She's been raising her hands, and she is an important colleague.
What I want to say is, remember what we're defining here is
Microphone, please.
Is pre-existing maternal disease or condition. That's what we're defining here. So if you're talking about what comes up later, then it may not be pre-existing, right?
Well, that's why we're debating whether to put it in the pre-existing that requires a physician referral and consult early on, or whether it's something that arises. It's moved to a condition that arises during the course of pregnancy.
So why can't it go in both?
I like that idea.
It's
the first pregnancy who have evidence of cervical incompetence.
Yeah, absolutely.
And we could list it as history of cervical incompetence with or without cerclage. And in current
B.
condition, in B, it would be current evidence of cervical incompetence. Perfect, I got it.
We could just say for B, evidence of cervical incompetence, because we are talking about the current pregnancy. Okay. Now, this doesn't mean that we don't have to talk about what's above or below. I'm just saying what's already been raised, so I know those are things for us to talk about. So 15 to next page, please. So I have something that was pretty duplicative, the history of postpartum hemorrhage requiring transfusion. And it was suggested, So I'm proposing that we do delete that, because under now 20, it was 23. It says history of severe postpartum hemorrhage, and then the suggestion is to add unknown etiology, because apparently if you're removing the placenta and it gets pulled on, that can cause the hemorrhage, and that does not mean that it's likely to happen again in the current pregnancy. And so, if it's known, and maybe we can even be more specific than that, but that's the current suggestion, and so open for discussion.
So what I'd like to propose is that as we go through these, we only ask for referrals where it's going to change the course of care. I can't, and maybe the physicians in the room can correct me on this, but I don't see what a doctor is going to do beyond maybe looking for coagulopathies if the woman has had a postpartum hemorrhage in the past. What will change in her course of care if she's under physician care?
I can answer that. If somebody has had a significant postpartum hemorrhage previously, then what would happen when I was caring for her intrapartum would be she would be cross-matched for blood, just so that if it happened, I'm ready. And the postpartum hemorrhage is one of those things that I'm sure that every single one of you, whenever it's a very, very scary thing. No one likes that. It's the thing that made me think I would take off my hat and all of my hair would have fallen out. It would have not just turned gray, not just turned white, but fallen out. So it can be very scary, and I know that you guys recognize this because you've been there before.
We do recognize that, but I don't believe that it should risk a woman out of having a home birth. We care for women that have had postpartum hemorrhages in the past and they don't hemorrhage with us, or if they do, we control the hemorrhage without the ability to replace blood at home. If it's a severe hemorrhage, she's going to the hospital and she's going really fast. But I don't think it's fair to suggest that piece of her history should disqualify her from the ability to have a home birth. And your response allows me to know that other physicians are going to see these women and likely have the same reaction and say, no, this could change the course of your pregnancy, you shouldn't deliver at home. When in fact, it doesn't have a hugely increased likelihood of changing the course of their delivery.
So my understanding of this list is that we're talking about things that you would refer and or consult with a physician on. Having something on this list does not prevent you or remove the option of a home birth, yes?
Well, it does if the physician doesn't agree. That doesn't determine that it's not likely to affect her current pregnancy, which is the difficult point, because
absolutely,
why would they say that when we can't predict ever how something's going to go?
And indeed, what it says is, except as well, a licensed midwife shall only assist a woman in normal pregnancy and childbirth when there is an absence of these conditions. So by making this list, we are saying these women may not be cared for by midwives.
Not accurate.
I realize that it does have, there's another clause in the law that says if a doctor allows her to. I think that is paternalistic.
Can we please stay on point? This is what I addressed. The statute says what it says, and we cannot change the statute here.
I'm saying that this item of previous postpartum hemorrhage should be struck. Period.
Okay, that's relevant, and that's what we need to talk about, but not the paternalistic statute.
But it's because of the paternalistic statute that I think this needs to be struck. That's why. It's because we have that part of the statute that says that women may not make this judgment for themselves, their midwives may not make this judgment for themselves, therefore they've got to see a doctor or they can't do this. They can't have what they want. Therefore, I think this should be struck. Because
you
we
can't,
all have
you
taken
can't
care
back
of women.
into it that way. If there's something on the list that it's not necessary for it to be there for consumer protection, then it should be struck.
I do believe that this does not protect consumers. I believe that what it does is it makes consumers less safe because they are more likely to go ahead with absence of care, with no care, with having unattended home births, because they're not being allowed to have what they looked at carefully. We have to realize women don't make these choices lightly. Nobody wants to bleed to death, or hardly anybody wants to bleed to death in the process of giving birth to her baby. And we've got to add that into our thinking as we go through this list. I do not believe that we should ever exclude a woman because she's had a previous hemorrhage. It needs to be taken into consideration by the midwife in terms of how we care for her. It does not mean that she should have to see a doctor in order to be allowed to have her baby at home.
So I have a suggestion that we keep the one that says history of postpartum hemorrhage requiring transfusion, and then we can decide whether or not to add or history of postpartum hemorrhage of unknown etiology requiring transfusion.
Why keep either of them? It's not going to change the course of care for home birth. It's just not. And it is going to significantly change the course of care for a woman in a hospital. What it is going to do is it's going to have a lot.
Come up to the mic, Carrie, please.
It's going to send a large number of women who have had hospital births in the past and experienced a postpartum hemorrhage back to a doctor, and then the doctor's going to be put in the position of saying, no, I don't think that's going to affect your current pregnancy. And we've already heard from one doctor in the room who believes it would affect the course of her care during delivery. There's a very large difference here between the medical model of how to care for someone with a previous postpartum hemorrhage and the midwifery model of care, which is what we're establishing here. We're not establishing a medical model. We're establishing a midwifery model. And we want to make the list comprehensive to protect consumers, but we don't want to make it so exhaustive that women are needlessly seeing physicians, and physicians are having to make judgment calls based on previous history that may have no impact whatsoever on the current pregnancy. This list is to create referrals so that a physician can determine whether that condition is likely to impact the current pregnancy. And it is no more likely to impact the current pregnancy than if you have a primate with a large baby. So how big do we want this list to be? And what kind of a position do we want to put our physicians in terms of helping us decide? We're perfectly competent care providers to talk to a woman about possible risks of postpartum hemorrhage, both those that have had one and those who have not. Our ability to care for her at home if she happens to be someone who has a postpartum hemorrhage in her current pregnancy, and what she gives up by not being in a hospital for her care. And then it's the woman's decision whether or not she wants to continue to birth at home or whether she wants to be in the hospital. But I don't see any benefit whatsoever to referring a woman to a physician if she's had a previous hemorrhage, for the physician to say, you're okay, you can, it's not going to impact you. Because I don't think that's the answer we're going to get.
If a woman has had a previous postpartum hemorrhage, we know that she is at least 2 to 3 times more likely to have another postpartum hemorrhage in a future pregnancy. That's just the little piece of information that we have.
So that's going to be one of the situations where a statistic like that is based on obstetric care in a hospital setting, and what we have available for out-of-hospital settings shows very low rates of postpartum hemorrhage. Most of those studies aren't large enough and matched to look at an individual woman's history to see their likelihood of recurrence. But since so many women who have second or greater births at home who had a previous hospital birth, we can definitely assume that a large number of them have had postpartum hemorrhages in hospital and not at home. And we can definitely go into the details of how the care is different, but it is one of those situations where the physiologic birth being protected at home, no Pitocin in labor, a different management of the delivery of placenta, definitely nothing else to augment the labor. There's a lot of reasons why the physiologic management is going to be different as far as postpartum hemorrhage outcomes.
Prenatal nutrition.
And I would like to say this is a case of we are making we are making stipulations based on risk rather than on conditions themselves. The woman who has had a previous hemorrhage is not ill. She does not have a condition. And I think that it is wrong to be telling that woman that she has to go to a doctor in order to be told that she's well. She's well.
And some of the situations that might specifically predispose her to a hemorrhage, like a coagulopathy or significant fibroids or something, are already in this list separately. So, we can discuss those as separate points, but they're already in here in different places.
But you had to already know she had the coagulopathy. The history of the postpartum hemorrhage is a trigger for one to look and seek to find the information of whether or not there's a coagulopathy.
Right.
Ms. Dobbs earlier seemed to be kind of questioning the difference between whether a variety of these history of ones actually do meet the statute, the requirement of the statute of something that's pre-existing maternal disease or condition. And I wonder how much we can look at if any of these history of ones are even actually required by statute.
Yeah, I think I was going to say something like that, but also I think the phrase likely to affect the pregnancy is really key. If we're talking about something where the underlying risk is 1% and someone with this history now has a 2 to 3% risk, is that actually something that's likely to affect the pregnancy, or is it okay to wait for signs of that actual condition or disease? Likely is obviously a very vague term, but it does not seem to me that a 2% risk of something happening is likely to affect the pregnancy.
In this case, we're looking at 5 to 15.
You're talking about obstetrics, not midwifery, and we're defining midwifery here.
I understand we're defining midwifery. I understand that. I just that when you look at the pool of data,
it's all obstetrics. It's not, you don't have a pool of data looking at midwifery outcomes other than our statistics over the last 7 years.
Exactly.
Right. I mean, so I get this.
Now that we're all in agreement, and I recognize this is not going to be an easy process, and I appreciate everyone's professionalism as we work through this, and these are important for all involved, so thank you all. Other speakers,
Hi.
Please say your name too.
My name is Maddie Shernock, and I'm a student midwife around these parts. And I was just thinking that the part where it says history of postpartum hemorrhage of unknown etiology. So in an intake situation with any licensed midwives, they're taking a good history, correct? So a licensed midwife who's taking a good history can determine if it's unknown etiology or not, based on the circumstances of the woman's previous birth, correct? I would think most of the time. Most hemorrhages are not of unknown etiology.
And that may be just superfluous language that is not helpful at all.
I think that unknown etiology is perfect, because that would exclude any woman who has had a postpartum hemorrhage because a doctor yanked her placenta out, right? That's
the idea behind
or she was induced with Pitocin, which is one of the biggest risk factors for postpartum hemorrhage, or had an epidural, or an assisted delivery, right? Okay, so I think that language is perfect. That's my opinion.
Carrie Sparrow. When I looked at this list, I also looked at the Midwives Alliance of Washington State's list. And in their list, they have 3 separate categories. The first category is discussion, where a midwife can discuss it with another healthcare provider, which may also be another midwife. There is a category for consult with a physician, and there's a category for transfer of care. All of these history of conditions are listed in the Midwives Alliance as discussion items. They're listed as if you have somebody who had a history of a severe postpartum hemorrhage, you should talk to a colleague about it and see what their take on it is, rather than have it be an immediate referral.
I'm looking at it right now, and that's why there's 2 of this. So one is under discussion, history of severe postpartum hemorrhage, but then there's the one that requires the consultation, that's history of postpartum hemorrhage requiring transfusion.
Right. But I think that neither of these as histories have we been working under since 2005. Part of our selection criteria did not include a history of postpartum transfusion, or postpartum hemorrhage requiring transfusion. And I think that what has been, maybe we just need clarification. Is history of consistent with the term in the law of a significant disease or condition? Is the history of something a condition or a disease? I would contend that it is not.
So, any pre-existing maternal disease or condition likely to affect the pregnancy. I certainly don't want to be overbroad in what's included on the list, because I know it is burdensome for consumers as well as for midwives. And I also want to capture the things that will create a dynamic that is likely to be dangerous for the mother of the fetus. So, again, open to discussion on it. And
it is an overbroad statute. And it's unfortunate to me, the law.
Okay, now we're not.
I know we can't change that.
Please help me.
Believe me, I know that you just said it. So I'm repeating what you said, Carrie. Basically,
No. I'm talking about the proposed regulation, not the statute.
I am talking about the regulation. Please give me just 10 seconds, because it is overbroad. I think that what we have to do in terms of the heading for this section of the regulation is to make sure that it is absolutely clear that any pre-existing maternal disease or condition that is pathological or clinically significant. It says for purposes of section 2507 of the code. Okay, I see that's in quotes. Okay, includes but is not limited to. It says right here, clinically significant evidence of a pathological condition. We need to add that in so that we are talking about true situations of current potential immediate and needing immediate within this pregnancy harm. Risk is not harm.
There's two different sections though.
I realize that.
Right now we're talking about any pre-existing maternal disease or condition,
and I would say pre-existing, and I know we can't change the statute, includes but is not limited to clinically significant evidence of pathological conditions that could create harm. I believe we need to add in some language here in this header for this section so that we are absolutely clear that we're talking about harmful situations, not just this great, huge, vague, overbroad language that is the statute. I think we need to hone it in. We've got to get more defined. And in fact, that's what you were talking about earlier. We have to make this more defined. We've got to create this so that the definitions are not going to leave mothers and midwives in this vast situation of paternalism.
Perhaps this particular one is something that the CAM and ACOG and other interested parties can continue to discuss to see if a consensus can be reached on its existence in the regulation and its wording.
Good idea.
I have one more thing to say if anybody wants to hear it. I think that I get where you guys are coming from in that, we write down and we define postpartum hemorrhage somewhat broadly in terms of if you lose more than such and such cc's of blood at the birth, and someone can have by that definition a postpartum hemorrhage that is not life-threatening, that qualifies as a postpartum hemorrhage, but that lady's going to be okay. And I think one of the ways to potentially weed those people out, when you look at postpartum hemorrhage in terms of just the strict milliliter amount, then you're going to have a whole lot of people, a whole lot more people that have had a history of a postpartum hemorrhage, right? But the number of women who've had a postpartum hemorrhage requiring blood transfusion is significantly smaller. And if we limited you got to talk to somebody or refer if they've had a history of a postpartum hemorrhage that required a blood transfusion. I think you'll take out some of the people that maybe that you're referring to that, oh, well, it was this happened in her care before, or that happened in her care before, or she got infected, or whatever the predisposing factors to that hemorrhage are, and you'll weed the number down to a much smaller number of people.
So what I would ask then is, if we send you this person who's had a previous postpartum hemorrhage requiring a transfusion, what will you do differently for her than what we could do, besides ordering type and cross for blood at delivery? What will you do during her pregnancy to assure that as best you can, that there won't be a recurrence? And how will that be different from what midwifery care might do to assure, to the best possible ability, that she won't have a recurrence? What do we gain, in other words, by referring this woman to a physician? What is gained in that? Because I think that's the whole point of this regulation. It's not to decide that midwives aren't competent to consent women. It's to create a list of items to refer for to improve care. And so I think we need to look at this list with that in mind. How will we improve her care if we refer her to a physician? And if we're not going to improve her care by referring her to a physician, beyond the physician saying, look, you know, if you're in the hospital, you can have a transfusion, which we can tell her, then it doesn't really belong on the list, I don't think. Because we're looking to protect women. And we have to make the assumption that midwives also want to protect women and that we are going to adequately consent them. You know, if we're reviewing a record and she had a postpartum hemorrhage that required a transfusion and she has one of those coagulopathies that precipitated it, guess what? She's coming to see you, at least if she's in my practice. But absent that, I don't see the benefit of making her go see you. She may decide she wants to see you, and that's a whole different thing. But I don't. Advise me, how would it change things for her to see you?
Okay. A lot of what's being done is with midwifery care would otherwise be considered the practice of medicine. But because you've got a license for midwifery, this category of care is being considered midwifery. So we're needing to make sure you're not getting into the practice of medicine. And one of my questions as a layperson here is, as a physician, are there things that if you had a patient come in that they hadn't figured out why they needed a transfusion, are there more diagnostic tests and things that you would be able to work up as a physician that might provide something that, so no, I want to ask the doctor that there's some things that you know, I'm concerned and confused about in terms of having something severe as a postpartum hemorrhage where you needed a transfusion, where it's unknown why that happened. So.
I'm sorry, I didn't understand. Are you asking her, is there something that she would do as a workup that the midwife could do as a workup?
Right. I'm asking in terms of the diagnostic process, because that's one of the big differences between the license types of the licensed midwife and in terms of the medical conditions.
So I think that they're talking about that a midwife is authorized to directly obtain supplies and devices, obtain and administer drugs and diagnostic tests, order testing, and receive reports that are necessary to his or her practice of midwifery and consistent with his or her scope of practice. So that's...
And I think what you're getting at is that diagnosis of a coagulopathy probably does not fall within the practice of midwifery.
But it's on the list.
If they have a coagulopathy. But that's actually the heart of the matter that you're getting at.
But it doesn't prevent us from ordering the background tests. We can, if we order a panel to look at different coagulopathies and they all come back normal, we're not diagnosing anything. If they come back positive for von Willebrand's or some other coagulopathy that will impact the pregnancy, we're going to send them to you to make final recommendations and determinations about this woman's care. They're not staying with us at that point. But until we have some diagnosis, I don't think, it's the same thing as ordering the prenatal screening. Until we have a positive result, there's no reason for us to send her to you to have that blood work done.
I think it's different than a prenatal screening because what exactly you order matters in this situation, whereas it's pretty well laid out in the prenatal screening. It's not quite as laid out in terms of coagulopathy. That's a little bit more tricky, and quite frankly, often can involve consultation with hem-onc. So I think that now we're getting into looking into things that are even at the edges of the scope of a general OBGYN and going more into the area of perinatology and hematology oncology. And so I think that I think that is it's a big point here, is that I really think that in terms of the history of postpartum hemorrhage having required blood transfusion is going to be kind of a sticking point for ACOG.
I've been up here a bunch of times without saying my name. I'm Rachel Hansen. I'm a licensed midwife. Just very briefly, that last thing you said actually really hits at a lot of the heart of this for me. A general practitioner is considered competent to decide when they need to refer to a specialist for follow-up with their patient. I don't understand why we, as licensed professionals, are not considered competent to know when we need to refer to a higher level of care in this matter as anyone else.
I get what you're saying, but we're here to do the regs.
Right, but that's a really valid point because it seems like underlying everything is the assumption that we don't know when to refer someone out of care or refer someone for a referral. That without doctor telling us what these conditions are, we just will, whatever, not know, we'll miss it. If that's the underlying assumption that's behind the argument, it's so unworkable.
I mean, I have taken care of people with say mosaic blood types, but the first time I did, and I referred her to the physician, and the physician called the hematologist, and this was 20 years ago, they had no idea what they were doing. When I had another woman with the same problem, one of her OBs told her she needed RhoGAM, and the other one told her she didn't. And it wasn't until her sister, who had had the same problem and figured it out in another state, called us. So these things aren't always under the purview of a physician going to have the right answer either. But individualizing people's care and keeping on it, like we're not taking care of 100 women at a time. We can give more personalized care. And if you're going to say history of hemorrhage requiring a transfusion, are you going to add of unknown etiology? Because the only 3 that we've had have been placental problems. And we knew what the problem was afterwards. There was a retained placenta, and she had a hemorrhage, and she had a transfusion. So 3 times in 30 years doesn't really call for, it's not a huge problem that you'd have to risk somebody out for, but you know why it happened. It's not likely to happen again. So there's a whole lot there.
Sarah? It sounds like we're probably not going to decide on this one and come to consensus on it. And I know there's a few more of these, and then also I know that you will be accepting comment, like written comment and stuff over the next few weeks or months, right? So there's ways we can do
and
that.
This is before we even get to the official notice and the official comment period. I mean, this is
I did want to just let you know
process.
that we do definitely have people here who specifically want to speak to history of cesarean. So I do hope that at least we can get to that today, specifically that one, because we were very prepared for it.
And also the age. Big flags.
I understand that that's an issue. I didn't make this stuff up. But if you have a woman who is older than 35 but is otherwise healthy, I don't see why we can't strike that. And again, that's a discussion point for the other stakeholders. If we can get consensus on striking the age 35 years or older at delivery, that'd be great.
I think everyone's fine.
Can I interject?
Of course.
My name's Allison Osborne, and a lot of the midwives that are here today have been practicing 30 to 40 years. 20 to 40, 30 to 40, lots and lots of years.
Are you a midwife?
I am. I'm a licensed midwife. And this laundry list or whatever is something that we worked on in California long before licensure. And originating with Faith Gibson's group in the Bay Area Guild of Midwives started what was called our laundry list of things to refer for and things to pay attention to. And at the beginning, we had nobody under 18, nobody over 40, because 40 was what was considered a big risk at that time. And then age restrictions went off completely. You know, I've worked with women and girls as young as 13 and women as old as 46. And this list is not something that somebody's inventing today. I doubt very seriously that most midwives want to be at home with somebody who's using with diabetes, insulin. I don't want to care for somebody like that. But I will tell you that in the state of California, in the county of Placer, one set of twins was born unattended because a midwife wouldn't attend them. One breech baby was born unattended because a midwife wouldn't attend them. We really have to, I'm not saying let's do breeches and twins. I'm saying that we really have to accommodate women in their choices and understand that midwives and midwives who are training the student midwives are trying to instill this sense of what is safe for birth, what is safe, and how to care for those women. So I just kind of wanted to throw that in. Safety is prominent in our thinking.
Can we strike the age 35 or older?
Yes.
I don't have a specific. I have no problem striking that.
And again, I mean, you don't have to carry the full burden by saying, it'll go out and hopefully it will not come about again.
I haven't introduced myself before. I'm Karen Ehrlich, licensed midwife of 40 years. I'll just make a group of comments since we're trying to get to cesarean and we've been hammering this one. There are several that I think, again, based on the fact that what midwives do is prevention, that we educate. And if somebody has had one of these conditions that we know of, what we do is, first of all, pay a lot of attention to helping to prevent the problem again. And second of all, monitoring more vigorously, more vigilantly, so that if the problem does repeat, that we will know in plenty of time to be able to get somebody referred. And those would be current or significant history of cancer, I would say of reproductive cancer. Because somebody who's sick with cancer is not likely to be coming to us who's really in a bad way. History of intrauterine growth restriction is something that many, many midwives have dealt with, women who've had that. And we help them to have full-term healthy babies. History of eclampsia, severe preeclampsia, or HELP. I certainly think that we know that it most of the time does not recur. Yes, there's an increased risk, again, of it recurring, but it most of the time does not recur, none of these things. And we are capable of understanding those situations, of working towards getting the health of those women improved enough that we can help them to not have a recurrence. And then if it does recur, we recognize these problems. And I think these things should be struck. History of gestational diabetes. Absolutely not. Lots of women do not have gestational diabetes in a subsequent pregnancy. It is another thing that with careful care and with monitoring, we can prevent and or know that it's happening so that we can refer at the time, so that we're not just dealing with risk, we're dealing with true conditions. I think that's what our women want. I would completely cross out any significant history of alcoholism or drug addiction. Anybody who is a current alcoholic or a current drug addict, it's a different story. I think history on those should be struck. I'm just trying to give an overall so I don't keep coming up here.
Thank you.
Okay, give me a second. I personally have no problem with striking history of IUGR. That's more likely to be something that has to do specifically with that particular pregnancy. the history of eclampsia or severe preeclampsia, I'm not so much happy to just check that off.
Would you check it off if it was not in the previous pregnancy?
So they had severe preeclampsia when they were 17, then they had a subsequent pregnancy at 23, and then now they're 25. Again.
You're still at high risk.
The problem with that whole thing is that you're at risk early on and later on, and so and if you've had the history, you're at significantly increased risk of having a repeat.
So
How would the manager? Yeah.
Because it's risk again.
Most of this, right, is risk. I feel like we have to be somewhat comfortable with the idea that we're making our best judgment based on the information that we have, and we recognize that it would be super easy if it was 100%, right? We wouldn't even be here, right? If it were the case that we were talking about walking into a burning building that were engulfed with flames, we could say, yeah, we know what's going to happen for sure with that. But that's not where most of this is. We know that you can run across the freeway and make it to the other side without any problems, but there's some risk involved with that, and so I feel like this whole process is kind of trying to define, like, from both sides where we can feel comfortable with what's okay for our population.
So I'd like to just bring us back to the question that I'm asking over and over again, which is, how would her care change if we sent her to you and you kept her, as opposed to her staying with a midwife for a history of eclampsia, preeclampsia, or health? We're in the situation again where what is being questioned is the judgment of the midwife, our training and our ability to diagnose these conditions that are specific to pregnancy. And I would make the case that we're all very good diagnosticians when it comes to diagnosing eclampsia, preeclampsia, or health. And the fact that a woman has a history of it doesn't really necessitate us sending her to an MD for the MD to do what that we can't do. That's what I want to know. What can an MD do if we refer her that will make her more safe than what a licensed midwife can do without referring her? Because we're talking about safety here for the woman.
I think that is an interesting question. I'm not sure that it's relevant to what we have to do with the regulation, because it doesn't say that a physician has to provide different care than what a midwife would do.
Well, it does say elsewhere that the physician must clear this person in order to stay with the midwife.
If we're not going to have a difference in care, what is the purpose of sending her? I can see that if she has insulin-dependent diabetes, the care will be different and appropriate with a physician, and she shouldn't be cared for by a licensed midwife at home. If she has essential hypertension, she's not a candidate to stay home. But those are actual diseases and conditions that are currently present. And what we're talking about in terms of history, I think we need to be really clear that there's a benefit to the woman in referring her for a history rather than a condition of disease that's currently present.
Karen, just to be technical on one of these things, I think where we're getting, and again, the medical board's got to look at the regulations that are fleshing out the details of the statute. And in the scope of practice, it says that midwives take care of women with normal pregnancies. So the question really shouldn't be whether or not Dr. McHugh is going to do something than you are. Is this a normal pregnancy? And so that is she at higher risk
The
question isn't, is she higher risk?
The question is not normal
pregnancy.
I mean, it's normal until it's not.
Right. Well, one distinction that might be helpful, but
Until it's not, that's a really good statement. And we're looking at, is she normal now? She is normal when she's sitting in front of me and she doesn't have a planned history, planned fear of health. Regardless of what her past history is, today she's normal.
But the other thing is she's supposed to have, does she have any pre-existing maternal disease or condition that's likely to affect the pregnancy? And that's when.
It's not.
But
So that's
I
the
guess
question I have.
I think that's where we're.
Clinical person in terms of if she is higher risk to have this condition.
But that's not
then,
what the statute asks for the determination.
Okay, can I finish, please? I think. Anyway, trying to keep my train of thought. So essentially, if she is at higher risk for a problem pregnancy because she's got this underlying disease or condition, that's when she needs to go for the consultation to the physician, and the physician may say she's not higher risk. So that's so.
But if history is something, it's not an underlying disease or condition.
Okay, but okay.
Maybe it would be helpful when we're looking at these history ones, because I know one of the history ones that obviously is a very big deal in obstetrics and midwifery is history of cesarean. So when you're looking at history of cesarean, this isn't exactly the nice, warm, fuzzy way that we want to look at it necessarily always, but that woman, as she stands there in the subsequent pregnancy, has an anatomical difference from a woman who doesn't have a history of prior cesarean. There is a cesarean scar. So when you're looking at a prior condition, there's something there. If we're looking at a history of one of these outcomes that doesn't leave an anatomical mark, is that really required in statute for us to define those histories that don't actually leave a current condition or disease for the subsequent pregnancy? And I think that's a question perhaps for the lawyers even more than for us as practitioners.
Okay. So for the lawyers, what we're trying to do here is we're trying to make the wording of the statute clear in the regulation. It doesn't define what it says any pre-existing maternal disease or condition likely to affect the pregnancy. Right. And so what we have to do in these regulations is work cooperatively to come up with what that is. So what we're going through right now is required. You guys have to tell us what it is, and then we have to make the legal determination based on what you tell us. So unfortunately, this process isn't an easy process. I don't have a clear legal answer for you because it's not defined. Our job today, as we all sit here, is for us to define it. And so we have to decide whether or not the things that we put on this list falls under this definition, and we really have to come up with a consensus together.
Thank you, Ben.
Yeah, that was really helpful because it helps me say what I want to say, which is the word likely to contribute to a poorer outcome the next time. Likely depends on whether you're looking at a midwifery model of care or a medical model of care. So in a physician's licensure, you are allowed to do your license to diagnose, perform surgery, dispense drugs, correct? That's what a physician can do. They're a physician and surgeon. They can diagnose, they can dispense drugs, they can do surgery, but they're unlikely to use the same modalities that midwives do to protect the consumer from an unlikely event that may be caused by her history. So when we do preventative things, we are talking, when, say, somebody comes to us with a pre-existing condition like hemorrhage or any of the other histories that are down here, we have diet counseling. We use herbs in homeopathy. We refer to acupuncturists and other alternative medicine modalities so that we can keep her from getting the thing that we're trying to prevent, whatever it is on that list. So it's not just waiting for the condition to reoccur and then treating it. It's using preventative measures all along the way. The woman who's a nurse who works all night long